It has been a difficult year for the world. Sickness, death, health services struggling and staff exhausted with Covid-19. A pathology of isolation, depression, violence, anxiety, while significant other disease was untreated, and waiting lists for routine care rose. Some 10% of people post-Covid-19 develop a long Covid syndrome. There have been problems providing protective equipment, PPE, for staff, a shortage of ventilators and oxygen. There have been risks translated into sickness and death for frontline workers in health, social and service sectors. As more has been learned of Covid-19 and its manifestations and complications, care has improved, case fatality rates have lowered. There has been a good deal of disagreement and debate about the strategy, the tactics, the use of resources and the response of governments. The true figures of mortality and morbidity may be unknown, withheld or massaged. Everyday life has changed, schools closed, offices shut down, home working, social life, restaurants, cinemas, sporting events, travel closed or restricted. There have been repeated lockdowns, border closures. The economy has shrunk, trade reduced. Jobs have been lost despite massive spending by governments. Vaccines have come, are making an impact. Some countries have managed well, and here life is returning to normal. In the poor countries of the world, the pandemic is out of control. Some 12 months on, a global disaster showing our vulnerability, our coping, our care. The picture still changes weekly around the world. There has been much human suffering, millions of deaths, and it seems likely that there are many months ahead. This is my attempt to make sense of the last year. The virus particle has a sinister beauty. This minute virus has changed our world, challenged our lifestyle. In 2019, it was unknown. We know about its genetic structure, its clinical manifestations. We can detect it in minute amounts in testing contacts. We can examine the antibody response and the development of individual immunity and the precious herd immunity, 60 to 80% of the population resistant and no longer vulnerable as victim or carrier. We can examine the virus around the world and detect early mutations and possible implications for infectivity and virulence. There are several coronaviruses circulating. They probably differ in infectivity and in their effect upon the person. The resulting clinical picture, morbidity and mortality. Viral mutations, sometimes more transmissible or virulent, have happened, with the concern that vaccines will be less effective in protecting against them. The speed of vaccine development, the technology of the genome, the trialling, testing and implementation has been extraordinary. The PowerPoint shows virus infections. A virus is a submicroscopic infectious agent that replicates only inside living cells of an organism. Viruses infect all types of life forms, from animals and plants to microorganisms, including bacteria. 6,000 virus species have been described in detail of the millions of types of viruses in the environment. Viruses are found in almost every ecosystem on Earth and are the most numerous type of biological entity. When infected, a host cell is forced to rapidly produce thousands of identical copies of the original virus. When not inside an infected cell or in the process of infecting a cell, viruses exist in the form of independent particles or virions, consisting of 1. The genetic material, i.e. long molecules of DNA or RNA, that encode the structure of the proteins by which the virus acts. 2. A protein coat, the capsid which surrounds and protects the genetic material. And in some cases 3. An outside envelope of lipids. The shapes of these virus particles range from simple helical and icosahedral forms to more complex structures. The virus enters or invades the healthy cell. The virus cuckoo then uses the endoplasmic reticulum of the cell to make copies of itself. Multiple virions are released as the cell dies. The cell itself is mortally damaged. The virus, many times multiplied, attacks many more healthy cells. The host becomes ill, but assuming the host survives, the host mounts an immune response, humoral or antibodies, and cellular or small lymphocytes. The host then becomes resistant to further attacks by that particular virus and is immune. This is the clinical picture and treatment of COVID-19. Diagnosis is initially clinical, taking account of exposure, travel, occupation, ethnic group, vaccination history, and other morbidity. It is confirmed by a swab from nose and throat from which the virus can be identified by its unique genetic profile. Prevention consists in minimizing social contact, lockdown, rules, travel restrictions, masks, hand and face hygiene, lifestyle, possible vitamin D supplementation, and then the next aspect is to test, trace and isolate infected people as soon as possible. To vaccinate the population in priority of risk and benefit, age, chronic illness, occupation. Treatment, antiviral drugs, ivermectin perhaps, favipiravir, steroids for severe illness, nursing hospital care, oxygen, ventilation, extracorporeal membrane oxygenation and ITU. Provision for prolonged care and best management of long COVID. The R number, the number of people infected by each person. This first outbreak was noted in Wuhan, China, in December 2019. This presentation is 1 year, 4 months, 1 week, and 6 days after that. At that time, there were 137 million cases confirmed in the world. Possibly 10% of the global population, or 780 million people, will be infected over time. Ideally, faced with an epidemic of an infectious disease spreading in the population, you would like to be able to 1. Test a random sample, 5 to 10%, for the virus every week. This will show the geographical distribution and pattern of spread. 2. Lockdown policy, travel restrictions and border closures determined by this data. 3. Test all patients admitted to hospital for other conditions, surgery, emergency, etc. for the virus. Isolate those infected. A rapid test essential to minimize the risk of infecting other patients. The patient needs to be retested before discharge and possibly while in care if exposed to infection. 4. Test all frontline, clinical and social carers weekly. 5. Monitor all positive COVID-19 patients for contact history and isolation compliance. A smartphone app can show contacts and their contact details so that they in turn can be contacted, tested, isolated and retested. 6. Determine testing policies or other vulnerable or at-risk groups. 7. Roll out vaccination program in the light of this information to try to minimize further spread. Slide 9. To minimize social mixing and if essential, make it as safe as possible. The virus is mainly spread by respiratory droplets. When an infected person coughs or sneezes, or by an aerosol in exhaled air in a closed space. Surface contamination of objects also occurs when a person touches an infected surface. They may self-inoculate themselves if they touch their nose or mouth. Prevention requires mask wearing, maintaining a distance from others, frequent hand washing, avoidance of crowded areas, closure of non-essential shops, gyms, restaurants, curfew, travel restrictions, lockdowns, and regular cleaning of potentially contaminated surfaces, door handles, bathrooms. Clinical and social staff require additional protection, masks, visors, eye protection, gloves and gowns depending on the intensity and duration of their contact. A testing of contacts and 7 to 10 days of isolation, smartphone apps and follow-up, vaccination of the population in precedence of risk. 10. Intensive care. Less than 1% of people with COVID-19 will require ITU. No country had the necessary ITU capacity at the beginning. There have been problems with setting up additional ITU facilities, equipment, ventilators, oxygen and drug supplies, and sufficient trained staff to man the beds. There may be an additional risk to staff if resuscitation is required. Occasionally, in grave cases, extracorporeal membrane oxygenation, ECMO, may be required. Once admitted to an ITU with COVID-19, the mortality will be over 30%. Slide 11, the Global Overview, April the 12th, 2021. There is some suggestion that 10% or 780 million people in the world have been affected. Possibly 10 million have already died. The COVID-19 epidemic is a long way from over, but there are many reasons to be optimistic, and it is possible the pandemic can be brought under control within months. Although January and February saw 6 consecutive weeks of plummeting COVID cases, the WHO has said that this has gone into reverse as cases come back in second and third waves. 12. The darkest areas show countries with 10 million or more cases. The present order is the United States of America, Brazil, Chile, India and Russia having the highest number of cases. Slide 13. It has been a year of deaths. There have been many weeks, 60, with more than 100,000 deaths, and for most of the world it continues. There are at least 3 million deaths to date, possibly between 5 and 10 million. The death rate will continue for many months to come. We will never know the true numbers. The Spanish flu of 1918 affected 500 million people, 25% of the world's population. There were between 50 and 100 million deaths. Slide 14. The deaths per million population. The United States, Brazil, Mexico have the United Kingdom, Spain, Italy have the highest death rates. Overall, the deaths per million worldwide are some 389 per million. 15. Death rates over time. The accuracy of the graphs is dependent on all countries being able to report all cases and all deaths in the same way. Death rates should also be standardized depending on the age structure of the population. So this slide has to be thought about quite carefully as to what it means. 16. The waves of disease. The concept of the wave is helpful where data is up to date and reliable, and where rapid action, isolation of cases and contacts is possible and lockdown measures enforced. The first wave of COVID-19 originated in China in December 2019. It spread across the world over the ensuing 3 months from east to west, reaching North America in May. There was a second wave in Europe in the autumn of 2020. A third wave is now seen in Europe, probably in Russia. Around the world, the distinction is less clear-cut, as the disease has smouldered, then broken out suddenly in a particular place and spread rapidly, initially locally and then to the wider population. Usually the first wave is most serious in terms of cases and deaths. Further waves affect fewer people as herd immunity has developed. COVID-19 has not behaved in this way. Herd immunity through low-dose, mild or asymptomatic infection has not produced protective antibodies in those so affected, and they have remained vulnerable in a second or third wave. 17. The spread of an infectious disease by droplets will be determined by the mixing of society. Initially, everyone is vulnerable. One person who is infected, particularly in the incubation period when they are not ill, can infect the other members of the herd he or she contacts. Some cases act as super spreaders, transmitting the virus in larger doses over many contacts. Disease spreads rapidly. Most members of the herd recover and are immune from further infection. Some will die. Eventually, if the herd has no outside contacts, then all of the survivors will be immune. The virus can no longer spread and the epidemic is over. Slide 18. The top box shows an outbreak in a community in which a few people are infected, shown in red, the rest are healthy, but unimmunized, shown in blue. The illness spreads freely through the population. The middle box shows a population where a small number have been immunized, shown in yellow. Those not immunized become infected, while those immunized do not. In the bottom box, a large proportion of the population have been immunized. This prevents the illness from spreading significantly, including to unimmunized people. In the first two examples, most healthy, unimmunized people become infected, whereas in the bottom example, only 1/4 of the healthy, unimmunized people become infected. Human beings are essentially social animals. We work, live, shop and congregate in clubs, pubs, restaurants, churches, football grounds, cinemas, theatres, for a funeral, a wedding, a party, a pilgrimage, a demonstration or a procession. We travel tight-packed on trains, buses, planes and ships. Crowds are part of our lifestyle. Herd immunity with Covid-19 requires at least 60% and probably 80% of the population either to have had the disease and recovered or to be fully vaccinated. Slide 20. Test, trace, isolate. PCR detects virus in a swab from nose or throat using the PCR polymerase chain reaction to multiply the virus where it can be detected by a suitable marked indicator. It is expensive, time-consuming, 24 hours plus, and 97 to 99% accurate. The lateral flow test identifies the antigen of the virus recognized by a suitable labeled antibody, akin to a pregnancy test. Speedier, 15 to 30 minutes, cheaper but less accurate, 70 to 90%, and problems with false negatives. There are also antibody tests which show evidence of previous infection or vaccination. In controlling the spread of Covid-19, it is essential to identify infected people as quickly as possible. They can then be isolated from the uninfected people and treated safely. Their immediate contacts need to be speedily identified, tested and isolated for 7 to 10 days. A contact may be considered where there has been contact at less than 3 meters for 15 minutes or more. Such contacts then may be contacted either via their phone or by a personal visit and advised about testing and isolation. If they become ill, they will continue isolation and treatment. If they are well, they can be retested and if negative, return to normal life. The smartphone, the app and the ability to record new cases quickly makes this possible, assuming most people have a suitable device and have loaded the app. 21. The demographic picture. The age group determines fatality. In the 0 to 19 age group, less than one person in 1,000 is likely to die. In the 70 plus population, it's probably between 8 and 10%. 20. The demography of Covid-19 in the world. Every country has been affected. Worst affected have been the Americas and Indian subcontinent. Different strategies have been used with variable success. For example, in China, total lockdown, fiercely policed for 3 months, rapid and complete isolation of the infected, test, trace and isolate enforced, rapid development of additional hospital and ITU facilities, border, regional and city closures, quarantine of new arrivals, stringent hygiene rules, early vaccination. Brazil, in contrast, denied that there was a problem. They were ill-prepared. There was minimal lockdown. There were no travel restrictions, vaccine denial, and then very limited vaccine supplies. The changing face of COVID-19, new mutations are appearing all the time, some of which have a graver effect on our life, health, well-being, and the concern that they will no longer be sensitive to the current vaccines. A medical nomad, I have worked in the UK, Zambia and Papua New Guinea. There has been time as a GP, as a Director of Public Health and as a Professor of Social Medicine, spending about a third of my working life in each. There has been medicine in the mud hut and medicine in teaching hospitals. I have talked to and practiced with prisoners and cabinet ministers, the poor and the rich. Work has always been interesting, sometimes terrifying, and mostly absorbing. I wouldn't have missed it. Slide 2. A world at war. We are at war with a common foe. The task working together requires communicating with the people, i.e. lockdowns. 2. Supporting the sick and protecting the vulnerable. 3. Hygiene, masks, mixing and travel. 4. Administering the guidelines of mixing, travel and borders. 5. Testing, tracing and isolation. 6. Vaccination for all with local priority. 7. Ongoing surveillance, cases, deaths and mutations. 8. Research. 9. Planned return to work, school, healthcare and recreation. Slide 3. Immunity and vaccine development. The path from viral analysis through to vaccine manufacture, testing, trialling and then rolling out is complex. 1. Viral genome sequence and mutations, viral lipid, protein, DNA or RNA. And human immune response, IgM, which is transient, IgA, which coats our mucous membranes, and IgG, which is long-lasting and in the blood. 2. Phase 1 trials in animals for immune response, toxicity and safety. 3. Phase 2 trials, limited human trials, immunity and safety. 4. Phase 3 real-world trials with large numbers stratified by age, sex and ethnicity. 5. Randomized controlled trials. 6. The cost of production, the contracts, the capacity, the patent and the profit. 7. The price, the market demand and pressures and the need. 8. Manufacture, plant, staff training, standards, quality control, materials and distribution. 9. Global need versus vaccine nationalism. 10. Persuasion and confidence, ongoing surveillance. 11. Hesitancy, trust, rumour and politics. Slide 3. The body's immune system recognises our own tissues by virtue of the proteins in our cells. These proteins are manufactured from our own DNA blueprint inherited at conception. Foreign protein triggers an antibody and small lymphocyte response to destroy or immobilize foreign cells. We become ill, but with recovery immune against further infection by that organism. The vaccine mimics this safely to achieve immunity without the risk of infection and illness. 1. By exposure to a similar but less virulent virus, e.g. cowpox, inoculation protects against smallpox. 2. By an inactivated virus still capable of producing an immune response, e.g. Sabin in polio. 3. By a killed virus, e.g. the Salk vaccine in polio. 4. By introducing fragments of the viral DNA or RNA using another harmless virus to carry it in a virus vector. The host then makes copies of these proteins. An on-release antibody is formed and protection against infection, i.e. a COVID-19 vaccine. 5. Messenger RNA fragments encased in a lipid envelope can be introduced directly into the host to achieve the same end, i.e. a COVID-19 vaccine. Immunization. Vaccines essentially prime the immune system with an extract of the virus, e.g. inactivated, modified, some protein fragment or viral DNA or viral RNA which are harmless. The body mounts an immune response, specific antibodies and small lymphocytes or T cells within 10 to 14 days. A booster vaccination after 21 days increases this immunity in terms of its greater effectiveness and longevity, i.e. years to a lifetime. Vaccines work. Vaccines provide 70% protection against infection within 14 days of the first dose. They provide 90% protection within 14 days of the second dose. People who have been vaccinated, should they become ill with COVID-19, are likely to have a milder illness and to make a full recovery. People who are vaccinated are less likely to carry the virus. People who have been vaccinated are less likely to transmit the virus to the susceptible. Doses administered per 100 people around the world: Israel 116, the United Kingdom 64, the USA 63, Brazil 16, India 9.2, Papua New Guinea less than 0.1. In Britain, in April, 42 million people, i.e. 49%, had their first vaccination. In the USA, 209 million, or 40%, had their first vaccination. Long COVID is a reaction after people have been infected and have otherwise got better. It is important to support and care for our clinical staff during times of difficulty and heavy work pressures by ensuring counselling, holidays and reward, and two, to be prepared to tackle post-COVID problems. 1 in 10 convalescents have symptoms after clinical recovery, but still present after 3 months and lasting 12 months or more. These include tiredness, mixed mood swings, confusion, and ME-type symptoms. The survivors and their fate. After the Spanish flu in 1918, some survivors developed a post-viral encephalopathy, a sort of sleeping death lasting for years. Encephalitis lethargica, as it was called, was a special interest of Oliver Sacks, the neurologist, who was seeing cases in 1966, more than 40 years later. He wrote about the condition in his book Awakenings, made into a film with Robin Williams playing Sacks. Some 10 years after Spanish flu, other people who had the disease and recovered developed Parkinson's disease in their 30s and 40s. This disease usually only affects those over 60. The question is, will there be similar and long-term sequelae for COVID-19 survivors? Human volunteers. To fully understand the dynamics of COVID-19 and the impact upon human health, human experimentation is essential. It is not without risk. Young healthy volunteers need to be insured, rewarded, and in the event of illness, have state-of-the-art treatment and care. Volunteers should come from all sections of society: men and women, different ethnic groups, the old and the young. Human guinea pigs. Human volunteers are being recruited, and only in this way can we fully understand and act. They will be paid, insured, treated optimally if they become ill, but they are taking a risk for all our benefits. The key questions are the natural history of COVID-19 by age, sex, morbidity and ethnic group, the infecting dose, the spread by droplets, aerosols, fomites, body secretions, tears, saliva, urine, semen, the excretion of the virus, the duration and intensity, the symptomless carrier, prevention by drugs, masks, distancing, isolation, lockdowns, vaccine development, prevention, protection, viral carriage in those vaccinated, and treatment options. The health of the people is the highest law. WHO needs a surveillance organisation with satellites around the world constantly monitoring, testing and reporting. Public health needs expertise in training and refreshing knowledge. It needs to be able to call in extra staff quickly. It needs to access local data, national advice, and freedom to take action appropriate to the region's needs. National agreement international agreement indeed on collecting and reporting cases and deaths, the ability to have reasonable supplies of protective equipment, hospital beds to cope with an emergency situation. Vaccine development is essentially driven by genetics and funded internationally to provide vaccination for all swiftly with agreed priorities. The cost. The cost to the world in terms of lost trade, output, service and market losses are in trillions of dollars. Enormous rescue packages, furlough schemes, special loans, social security payments have reached unprecedented levels. Businesses have closed, some will never open. Jobs have been lost. The way we live now has changed more in 1 year than in 100. The greater cost has been to human happiness. The national consequences. Deaths. 0.1 to 0.3% of the world's peoples have died. The disease, 10 to 20% of the world have suffered illness, and of those who have been ill, 1 to 3% have died. A huge struggle to provide health care and too often failing to do so. Loss of confidence and trust in the WHO, in national and regional government. Damage to the credibility of world leadership. A massive blow to the world economy with long-term damage, particularly for those who earn less than $2 American dollars a day. The personal consequences. The deaths where family visits were forbidden, the limited funerals, the curtailment of mourning, the pressure to hurry and to bury large numbers swiftly, the many sick, some desperately so, with long weeks of intensive treatment and slow recovery, the long-term after-effects on physical and mental health, the intense pressure on clinical staff, shortages and failures, the effects on schooling, education, examination from the kindergarten to the postgraduate, a loss of jobs, closures of businesses in hospitality, travel, holiday and arts, a life with months of restriction, loneliness and anxiety. The post-mortem. Any inquiry needs to examine the picture at local, national, international and world level. It should consider surveillance, active and rapid escalation, warning, local, national, international, data, positive tests, clinical cases, ITU use, deaths, vaccine rollout, staff, stress, strain, train and risks. The response, training, equipment, healthcare, trace, test, isolate. The results, infections, deaths, chronic illness, other medical needs, prevention, protective equipment, lockdown, public hygiene, border control and vaccines, costs, direct and indirect. Justice, fairness, inquiry. There are some 29 million refugees in the world today, a third within the African continent. While the people of the world are better off than ever before, there is still a huge gap between the rich nations and the poor nations. Covid-19 has shown the unequal effects on rich and poor. Perhaps the world might learn to do better, for until all are vaccinated, nobody is completely safe. Rich world, poor world. The rich first world is anxious about population numbers. Its own population is steady but aging and increasingly dependent. It does not welcome refugees or asylum seekers. It is a consumer society with heavy use of the world's resources, conspicuous waste and promiscuous pollution, all in the name of profit. It does not want to change its lifestyle and expects the standard of living to improve annually, and it usually does. The poor third world has a young population. Babies are surviving, but growing up into communities where space, food and work become increasingly scarce. 50 years of aid and effort have been significant, but there is far to go. The poor world needs to emulate the rich lifestyle, the style of the Americas, but the chances are diminishing and the option of migrating out is difficult. A massive Covid-19 outbreak is a disaster for all mankind, but also a warning siren. Just perhaps we can do it better next time round. How might we go forward? With humility and gratitude, not fife and drum, but kindness, hope and compassion. There is still much to research and understand of critical importance in determining the best way forward. Different parts of the world are at different stages in the pandemic. Poor nations have been and are suffering. They too will suffer most. Returning to normal will be difficult and step by step, guided by the data. Lockdowns, reopening, travel, border control. There will be occasional sporadic outbreaks requiring swift action, isolation of the case, urgent contact tracing, surveillance, and ring vaccination of the surrounding community. To accept this story will be further months, if not years, in the true telling. I will end with a poem. Humanity, you are all one. You are one beloved community, and you are one global sickness. You are all contagious, and always have been, unconsciously infecting and yet able to also bless one another. There are no higher and lower in this world. There is no smart or stupid, no totally right or totally wrong. The only meaningful division is between those who serve and those who allow themselves to be served. All the rest is temporary posturing. Many to whom you look for power and leadership have shown themselves to have empty hands, minds and hearts. We are bereft of all satisfying explanations, all ledgers of deserving and undeserving. There are no perfect answers or absolute heroes. We must all wear a mask to protect the other from me.